first, I want to thank SJ and his team for inviting me and all of us actually to this meeting, and giving us the opportunity to participate in this live case. So we have a great team. With me is Dr. Park and Dr. Chang, and we have some wonderful nurses and technicians here. So Dr. Park, we'll go ahead and present the case.
Yes. Hello, and here is our typical hybrid room. Is Raj Makkar. Is very happy to collaborate with him. And Dr. Kang is our cardiac surgeon. Dr. Kim is already standby over there. So, and I'm going to briefly the present patient. Is a 7-year-old male. Is main symptom was dizziness and pre-syncope several times. The echocardiography showed the CVRF and the normal ejection fraction. Looking at his past history, nearly 20 years ago, and he experienced MI and received the right coronary artery valve stent, and we already checked coronary angio. Stent was patent. There was no additional region. And 1 year ago, he experienced a stroke, but there is no sequelae and mild COPD. And next. And there was no diabetic, no hypertension, and looking at the STS score, literally 2.25 is a low-risk score, but 79-year-old male, he definitely reluctant to receive bypass surgery. And next. And echocardiography, and looking at the aortic valve area was 0.6, a very tight lesion, and the ejection fraction 56. There was some small arch territory wall motion abnormality. Next. So this is next. Okay, this is our routine 3D CT algorithm is measured. It's the short diameter is 21, long diameter 24.7, and the area is 422. Perimeter is 74. And next. And the sinus valsalva, the sinus annulus area ratio was 1.98. Is similar to our mean, and looking at STS junction is 1.74. And next. And this is the LVOT. There is no the LVOT calcium. The LVOT area is okay. And next. This is the calcium score is very low, which is the 107 millimeter scale. Is next. Is looking at the coronary height. Is the left is 12.1 millimeter sufficient, and RCA is 15.9 millimeter is sufficient. And next. And there would be some debatable portion, and we select SAPIEN 3 and the 26, and there would be some mention from the Raj Makkar.
Sure. Yeah, so, thank you so much, Dr. Park. I think that was a beautiful presentation. So it seems like, as you looked at it, the access is pretty favorable. The valve is not very heavily calcified. The sinuses are of good caliber. There's no LVOT calcium. The coronary heights are pretty good. They're pretty standard. They're more than 10. So there are some good favorable features here in terms. We don't see any hostile features. I think the important question here is, the size. Now, he's a man, and, the maximum dimension was almost close to 25, though the mean dimension was 22.9. So I'm inclined to use a 26 millimeter valve. Now, if you do a 26 millimeter valve, you're going to end up with, the area oversizing is 123. All right. So what we'll do is we'll take a 26 millimeter valve and maybe take a cc or two out. We talked about this. I'm actually, Dr. Park, I think I want to take 1 cc out and not 2 cc out as I'm looking at it. So I think we can do about 15% oversizing there because there's not much calcium.
Yeah, right.
All right. So I think that's, let's make sure that we take 1 cc out and not 2 cc out.
Yeah, okay, great.
All right. So our patient is, we are doing this with conscious sedation, which is a little bit different than how we do most of our cases at Cedars, where we tend to use a TEE to guide us. Let's go ahead and get started then. So, right? Okay. Any other questions about the case?
No, that's it's great. We can see that Dr. Park gave you the good room, so gave you the good team, gave you the wonderful nurses. You found that out very quickly, and we wish you good luck, Raj.
All right, terrific. So, okay. All right, so I think it's pretty standard now that's interesting that without making any efforts, we got lucky here and the valve. All right, so let's go ahead and I didn't really get to demonstrate how to cross the.
So you were actually faster than SJ. SJ had it in 2 seconds. You just did it in no seconds.
All right, so I'd like to go ahead and get the baseline hemodynamics.
That's why you have that funny laughter of SJ in the background.
So no, SJ is always faster. And
no.
All right.
Terrific. We were surprised that he was waiting for the results for. That's not exactly what I expected.
Okay. All right. So we routinely measure gradients. I think it's a good practice, at least in a teaching institution. All right. So let's look at our LVAO pressures.
Aortic pressure. Okay, got it.
All right. That's. Are we properly zeroed? Because these gradients don't look very dramatic, I have to say.
Yes.
So
it's always the case.
Yes. All right. So I think, see, this is where if you had a TE, you would get a good second look assessment of the valve in cross-sectional view, and you would make sure that the valve is truly tight. But I think there is a very good echocardiographic data from before that sort of was quite convincing that this is indeed severe aortic stenosis. Okay.
Yeah. That's why we don't do.
All right.
Okay.
Okay. So we will go ahead now, and
this is extra stiff.
Any thoughts, Raj, on the pre-dilatation issue?
As I'm tempted, I see no reason to actually pre-dilate here. So there's not much calcium.
Based on your experience, or are you using SJ's score, or what is your?
I think that there is not much calcium here.
Right.
We tend to, Dr. Park, will you walk this out? I'll hold the sheet.
Okay,
here.
got it.
All right. So we tend not to pre-dilate. I think SAPIEN 3 valve is very easy to cross with, unless the valve is really calcified, or if it's a bicuspid, or if the aortic arch is very horizontal. Yeah, let's. Oh, that's so we no. Yeah. So we have an interesting situation here. We realize that our wire is actually short, so we'll go back, recross, and
life case.
Yeah. All right.
잘 보고 줘야지. Okay. Okay, got it. You make a. Okay. Okay.
All right. Okay. All right. So let's go ahead and make another bend here.
Yes.
All right. This should suffice. So I saw that SJ used the Safari wire. We tend to use, I tend to use this wire. It works nicely most of the times. So Dr. Park, if you can walk this out and without losing our...
Extra stiff?
This is
this is the Amplat extra stiff.
Yeah.
Not the super stiff, extra stiff.
Got it.
You just skipped the pigtail exchange, right?
Yes. As you saw, what I do is I put the Amplats, the AL1 catheter, so that the tip is actually hugging the anterior wall, looking up, which just allows us to put the wire in a favorable fashion. All right. Okay. So let's go ahead and can we show them the aortic root angiogram, please?
Aortic root angiogram.
Okay. So what we did here was, so you can see that this is our deployment view, which is caudal 23, RAO8. You can see the three cusps. They're fairly well aligned. I think so. This is what we predicted based on CT, and I think it is pretty good. So, I heard earlier the discussion about the valve being too high, but I think that is what I like to do now. In fact, the deployment of the valve high is, I think, what has really been effective in terms of reducing pacemaker rate, even with the SAPIEN 3 valve. So we are going to try and do the same thing here. Okay, we're going to try and land it high.
Okay.
Okay. So can we get the valve ready, please?
Valve ready? He's crimping.
While we are waiting for the valve, we just want to share with you the way we, can you show, we use the micropuncture.
Okay, got it. Could you show the image?
Just want to show you that this is
the left side puncture.
Left side.
4 French micro catheter.
Right. So it's a 4 French, but you know, that's the outer. The inner is like 1 French.
Yeah,
so that's like a 1 French, and if you don't like it, you can come out and just put pressure for 1 minute and it doesn't bleed. And we did the same thing on the other side. All right, so here is the micropuncture.
Yes.
So in this case, the stick was a little bit low, so what we did was with this thing there, you know, a little bit of injection, we punctured it again. All right, so we want there to be about 2 centimeter at least between the puncture point and the bifurcation, so in case we have a vascular complication, we don't compromise both the profunda as well as the SFA. All right.
Okay, guys.
Okay, so our valve.
You aim for high implant. So what is the upper limit that you accept?
I think that I'd like for it to be 90-10, but at least 80-20. You know.
80-20. Okay.
Well, I'm not against high implant. I'm just against too high implant.
Yeah. So the other thing was the coronary access. So Eberhard, I heard you talk about the coronary access. So we've done multiple interventions through the strat. Most of the times now with SAPIEN 3, you are actually sitting across the left main anyways. So there is no problem in accessing the left main. As you mentioned, that the upper cells are actually quite large. All right. Yeah. So we're going to go ahead and advance our valve. Okay. Let's see. At times, I find out that it is very hard to advance this. So I'm always tempted to let my fellows do all the pushing here when I'm doing cases at home. All right. All right. So see, our wire has come back a little bit, so don't pull it. Just let it go forward, please.
Yeah.
All right.
Okay, got it. Okay. Okay.
All right. Okay. So let's go ahead now. So we're going to assemble. All right. So what I will do is so we'll unlock and you're going to pull. Now, see, as you pull back, we are going to lose the wire position. So I'm going to advance this a little bit.
Yes.
Okay, as you pull back.
Okay.
All right.
And then
so we would not have this issue if you're using a pre-shaped wire. You know, there is enough of that. But with this, we have to be a little bit more careful.
Okay.
All right. Okay. So pull back. Right. So lock this as we see the white. Now we'll go ahead and use. Yeah. All right.
Just a little bit more.
A little bit more. All right. So one of the So this is well assembled now. So if you are going to hold the wire. I'm going to bring it forward.
Okay, got it.
Yeah. Let's move the table a little bit, please. All right. So at this,
So I hold the wire.
All right. So, you know, okay, can you give me a little tension on the wire? So
got it.
So what I want to do is, I want to stay away from the outer curvature of the aorta, all right? Because that is where the plaque can come off. So, see, this is where you are important. You have to give me a little tension.
Okay, I have tension.
All right. So a little bit more tension. In fact, you can just jiggle the wire a little bit.
Okay.
Yeah.
Okay, got it.
Okay, so our wire has come back.
Yes.
All right, so please, All right.
Okay, got it.
All right.
Nice.
Okay, so.
I always like jiggling.
Yeah. I think it helps with the centering it.
And then coplanar view.
So we are now going to go to the coplanar view. You see, there's not a whole lot of calcium.
It's a vital.
That we see.
Okay.
All right.
Okay. zoom하고. Okay.
All right. So I think we see our landmarks a little bit better now in our deployment view. You see the calcium. Okay, so let's give me a just a little test, please.
Just a little test.
All right.
이거 딱 신경 써서.
Okay, let me bring this pigtail catheter down. This is our deployment view, right?
Okay.
Okay, so let's just go ahead and take a picture.
Okay,
let's just go ahead and take a picture to make sure, since we are working for the first time together.
Okay, got it.
All right, here.
Take a picture.
So let's just go ahead and take a picture together. Okay, all right. Please take a picture.
Take a picture.
All right. So I think this is fine.
Yes.
Okay, it is going to foreshorten from below. But what I'm going to do is I'm going to keep it there so that we end up in a higher implant, okay? Maybe I'll come down a tiny bit, okay?
Yes.
I think, test please.
Test.
I
Okay.
like that.
All right,
Right.
yes. Okay. All right, so I think we are ready to go ahead and deploy this.
Okay.
Okay. All right, is everybody ready?
Everybody ready?
Okay, so please listen to me.
Yes.
All right, Dr. Park is
The
going to
pigtail
go
back.
up.
Okay.
All right.
Okay.
So we'll do the pigtail back as
Okay.
we are going up.
Yeah.
Okay. So that's what we do. All right. Okay. So is the pacemaker ready at 180?
Yes.
Pacemaker on, please.
Pacing.
Inject, please.
Inject.
All right. Let's go up.
Okay.
Let's go up.
inflate,
Yeah.
inflate,
Up. A little bit faster. Yeah. Yeah. Go up
Okay.
faster. Up. Down.
One,
Off,
down.
please.
That's a good one.
Pacing off.
All right. Pacer off. Yeah. Pacer
Okay,
off.
facing off. Okay, facing off. Okay, great. Wonderful.
All right. Okay. So let's see now. Okay, so hold the wire, please,
Yes,
and let
yes.
me take this back.
Yes, I keep the hold wire.
Yeah. All right. What's our blood pressure? It's
Yeah.
okay.
Can you show the blood?
All right.
혈압 좀 체크해 주세요.
All
Okay.
right. Is our rhythm stable?
Okay. Okay. Blood pressure is okay. Okay.
All right.
자, 페이싱을 좀
Pace.
백업해봐.
Yeah. Go ahead and
Pacing, 100.
just pace at 100.
100.
Okay. Just for
Okay,
a little
got it.
bit. Let's do that.
Okay, got it.
Okay. We'll come back and reassess the rhythm a little bit. Let's. Okay. So let's just take. I want to go ahead and pull this back a little bit. Give me a little injection, please. What I'd like to do is go a little. Let's make the valve a box. It's
okay.
not coaxial. So let's move the II, please. Go a little caudal or cranial and see. Yeah, a little bit more caudal in the other
Caudal.
direction. In the other direction. Yeah. Okay. Better. All right. All right.
This is much better.
Yeah.
Okay, got it.
Okay, all right. So let's go ahead and take a picture there to see what our valve looks like. Inject, please.
Injection.
All right.
페이싱을 한번 꺼볼까? 얼마나 어떻게 나오나? 네, 줄여보세요.
Okay.
60.
So, yeah, so
This
it's,
is 6.
I have to say that I would have liked to be higher a little bit, all right, but I think this is, I don't see much, this is a pressure injection, I don't see much leakage there. So what we'll do is, and we have a wire there, so let's go ahead and switch. I'm going to take this out. Our left main looks okay.
Yes.
Now we did, we had 1 cc out, right?
1 cc.
Okay.
Yes.
What we'll do is we'll take the system out. Okay. We are going to put a multi-purpose catheter, and we are going to take some echo pictures.
Okay, got it.
All right.
Yes.
Okay. So we can always come back to post-dilate.
It's a multipurpose.
All right. If we had a TE, we would just keep the system right there,
Yes.
and
Okay, got it.
Okay.
Okay, got it.
Ray, do you check the hemodynamic afterwards?
yes.
Yeah, right.
Yes. So we are going to check the hemodynamics.
All right. It's different from HA's practice.
Okay, got it. 자, multipurpose 준비했고. Okay,
Yeah.
got it.
Yeah.
Okay. 자, 준비하고. Wire is okay, great.
All right.
자, 잡고 push
So
it.
this is, here the valve is coaxial. It's not the annulus plane of the annulus. Okay. All right.
This is a multipurpose.
Yeah.
Okay.
All right. All right. Okay.
Okay, got it.
So let's go ahead and measure the.
자, 빼고.
Okay. So can we look at the echo, please?
Is doctor, can you check the echo?
And then can we go ahead and come down on the pacemaker rate?
Turn down the pacemaker rate.
Maybe to 80, so that we can slowly start to come down and see
80으로 해봐.
the patient's rhythm is back.
Okay. 네.
Are we able to? Are you able to see the transthoracic echo?
저기 우리 에코 한쪽 뷰로.
All right.
not
So,
yet.
Okay.
all right. Can we please go ahead and show the transthoracic echo?
Okay, got it.
Yeah, now we see it.
All right. So, can we look at the hemodynamics there, or they don't show up on the Philips system, Philips
There
hemodynamic
was a
system?
hemodynamic.
All right. So there you can look at the hemodynamics.
Nice. You're still on the pacer, right?
We came down to 80, but it is still
80.
pacing.
Yes.
Okay. So what do you think? Do you see any paravalvular AI or any AI?
There's only pinpoint
Pinpoint AI.
paravalvular
Pinpoint.
leakage.
Yeah.
Pinpoint AI. All right, so I don't see much there. And I
Yeah,
think
yeah.
that whenever we do these pressure injections with 800 PSIs, I think we tend to see a little bit of,
Yeah, right.
but I'm not looking, but let's scan through this carefully.
I actually think, Raj, that the depth is really nice. to
I
be
actually
honest.
think that because I think it's fine.
Yeah, I
you know-
really do.
Yeah, I think it's fine because we are at the level, yeah. And whenever you have asymmetric calcification, you can. So the question is whether it would be a little bit more coaxial, but it's fine. It's acceptable.
Yeah.
Okay, so I don't see any AI there.
Yes.
Does anybody disagree?
I think you're good.
Okay. All right, so we are going to go ahead, and there's no reason to do any further dilatation.
right, right.
Does everybody
Dr.
agree?
Kim, agree? He's getting ready, Raj. Wait.
Huh?
You'd
Dr.
like
Kim
to
is getting ready.
Yeah, you'd like to see the root arterography with several different projections to see the focus of regurgitation on the angiography. I think TT is not accurate, underestimating. Let's please see repeatedly the arterography to measure exactly, because even we chose a bigger valve with 1 cc minus, but if there is a kind of a pinpoint regurgitation, annulus is less calcification. Thus, when we perform additional ballooning, there is no risk of a tear. Just please do.
No, it's not. So it's not about tear. I mean, there is a possibility of tear. I would not rule that out. We also know that post-dilatation, when not necessary, should not be done because there is a small but definite risk of stroke. In this patient who's had a prior stroke, I think it would have been even prudent to consider using cerebral protection. And I think we should, if there is no need, I think we should not hesitate to post-dilate if there is a need to. But I am personally not impressed by, we're looking at the hemodynamics, as you can actually see. On this monitor, the diastolic pressure is actually much higher.
Yes.
It's about 65, 70 millimeters of mercury. And if you look at the hemodynamics, they're actually quite favorable there. So the AI index is...
I think regurgitation at this angio is mainly due to the stiff wire.
Yes.
So when you repeat the angiography, we
That's
can
correct.
exactly assess
It's possible.
regurgitation.
Okay,
Yeah,
got it.
so I think, but I think that I'm not compelled to post-dilate, but we can go ahead. His creatinine is okay.
Yeah,
Right?
creatinine is okay.
Okay,
Yeah,
so
right.
I think we can go ahead and do that.
Yes.
Okay. All right, let's just do one more injection. Okay?
Ready?
All right, inject, please.
Sure. Absolutely.
All right,
Excellent.
there's,
Just
there's-
trivial.
yeah.
Yeah, wonderful.
All right, so I don't see much at all there. Okay, terrific. I think we shouldn't. We should be like SJ, and there's no reason to be there any longer than we need to.
Quick remove.
All right.
Yeah. Okay, got it.
All
Wire.
right, give me a J wire,
Wait,
please. So let's go ahead and close this.
Yeah, okay,
Give me a catheter. I want a soft wire. Give me a soft J wire. And then I want to go up and over on the other side
okay.
while we close the.
Ray, can I ask you questions?
Yes.
Well, you just gave us a great talks on the subclinical leaflet thrombosis, which tend to occur in 20% of cases, higher incidence of TIA.
Yes.
Well, this 79-year-old gentleman history a stroke last year. So it would be interesting to know, will you anticoagulate patient right away or routinely do the 4D CT to look for subclinical leaflet thrombosis for these particular cases?
I think that without being dogmatic, I think it would be a reasonable thing to say, let's go ahead and start this person on anticoagulation for 3 to 6 months, but at the same time acknowledging that we really don't know the right answer. But it's a very reasonable thing to actually do that in this case.
Well, can we identify any risk factors for these subclinical leaflet thrombosis? We don't have a chance to ask you during your
what
talk.
we know is that, you know, of course, besides not being on anticoagulation, you know, the age is a predictor. All right, so older people tend to have that. Now, we are systematically looking at coagulation factors. So you know, I think it'll be interesting to see if that pans out in any way. What we know is that with self-expanding valves and even with the balloon expandable valves, when you deploy them deep or low, the risk is higher. We also know that when valves are not properly expanded, for example, especially with the self-expanding valves, for example, with portico, you know, when if you don't do a good post-dilatation, and if the valve is not properly expanded, you're going to have. Oh, where is the wire? Where is the J wire, please? Huh? Give me. Is this a J wire? Regular J wire?
Regular J wire.
Yeah. Please give me a regular J wire.
Okay, got it. 이건가? Regular J wire 줘보세요.
So I think those are some of the predisposing factors.
In these patients.
Yeah, so this is a patient.
Stroke here.
This is a patient. I would definitely have used cerebral protection.
He would. Raj actually is using it commercially already in the United States. Well, did you hear what he was asking, Raj?
Yes. So I think it was about cerebral protection. So at my hospital, we have decided, at least for now, that we are going to use cerebral protection in everybody unless there is a reason not to. You know, so if they don't have good assessment of the anatomy, or if the anatomy is hostile, very tortuous, you know, then we will not. Otherwise, we do use it. So, you know, with that approach, we are now using cerebral protection in almost 80% of our cases.
Wire?
Is it fully reimbursed in the US?
Okay.
No.
Yeah.
No.
It is not reimbursed, so that is a problem. You know, it is rolled into the overall DRG. All right. We don't have the up and over catheter, huh? All right. Is this sheath sutured? Okay.
Yes,
let's cut the sheath, please, huh? I think the data are convincing. If you look at the peri-procedural stroke rates, I think what we did, you know, wrong in the designing of the study was looking at 30-day stroke rates, which are low, but you know, they were not as dramatically low as are the 72-hour stroke rates, which is what is relevant, you know, which is what is relevant when you talk about an embolic protection device.
This patient definitely a very high risk. History stroke last year, so definitely indicated.
Yeah. All right, so I'm going to go ahead and pull the sheath back.
Yes.
Okay, so we need somebody on this side to come.
Yeah.
Yeah.
Okay, 닥터 over there. Okay.
Yeah.
일로 와서 눌러.
So
이쪽으로 와서.
we'll bring this back. Okay. So I normally use a catheter, like a. This is the JR4. I normally use an up and over catheter, you know. But let's see. I think this should be okay. Do you have a Terumo wire, a soft angle Terumo wire, please?
테르모 와이어 주세요.
All right. So this is not coming down as well, huh? Okay. That's
Okay, got it.
Okay.
Do you want to 테르모 와이어? 줘.
Angle. We can also leave. Yeah.
Okay, got it.
All right.
This is 테르모 와이어.
How much more time do we have?
얼마나
I think,
남았어?
Are we?
I don't know, 15 minutes or so.
15
Okay,
minutes?
all
Yes,
right.
we have
Okay,
enough
so
time.
we have enough time.
Okay,
So
got
we'll
it.
just do this. I will pull this back a little bit more. What wire is this? This is a 30. All right. Well, I have to say, there's some. There was a plaque there, and I think that is what is. All right. So we won't keep persisting. Let me see if I can pull back a little bit more, and will that bring this further down. All right. Okay, I think that it's reasonable not to keep fighting this. All right, we'll take a picture from there. It's all right.
Got it.
Okay, let's just come here. Come down, please. Okay. So. All right, so go ahead, please. And what we typically do is you go ahead and do this. You hold this. All right. Okay. Okay, you put pressure here. You just hold it. Don't pull it too much. Okay. We leave the wire in.
Okay, got
We'll
it.
pull this back. Okay, so this goes down. All right. Okay, we'll take this. Okay. So this is good. This doesn't look bad at all.
Yes.
We'll just put. Can you go ahead? We'll take a quick picture.
Okay, got it.
Okay.
Okay, we are ready?
Are you ready?
Yes.
Okay. Inject, please. All right. So that looks all right.
Yeah, right.
Okay.
Good.
So just a
Yeah.
tiny ooze here.
Yeah.
Can we go ahead and, so we like to reverse the heparin
Heparin,
with
reverse
protamine.
heparin.
So typically I'll give 20 milligrams of protamine.
Yes.
So can we go ahead and do so? All right. Okay, and we'll go ahead and cut the sutures.
Yes.
Okay. All right. So can you hold some pressure, please, here?
Okay.
A little bit.
I'm not.
Is everything all right?
Okay.
Okay, so I think it's important to know what is happening to our rhythm now, right? So can we come down on our rate to 60 and let's see.
60.
Okay, let's put pressure. We're going to put pressure for a few minutes.
Temporal pacemaker.
5 minutes. And, okay, it'll be fine. Okay, so just a little bit here, huh? Okay, so let's give protamine. So are you down to 60?
This is 60.
Okay. So we see that there is a, yeah. Okay. So what do you think about, okay, can you come down further? I mean, come down to 50?
50.
Was his initial rhythm sinus?
His rhythm was sinus. There was a little bit of QRS prolongation,
Yeah,
but not very dramatic, right?
Yeah,
Huh?
right.
Okay, so I think that this is a patient where you continue to pace, and you know, a lot of times by the time you make arrangements to put in a temporary screw-in lead, the rhythm comes back to normal. But it would not be unreasonable if you needed to put a temporary lead and watch him, you know, overnight. Just leave the lead there
right.
and watch this patient.
Our routine is just to take care at the coronary care unit. Yes.
Yeah. Okay. So, are there any other questions, comments?
Anybody here that has any comments? No, Raj, I think that's great. You have shown us another successful sapien case, the Raj Makkar way. And great success. Thank you very much from beginning to closure. And congratulations to a wonderful case.
Right. Okay,
Thank you
terrific.
very much.